Okay, y'all, welcome. Third day. We appreciate you being here. This is lung health and CF, pretty broad topic, but we got some pretty interesting stuff coming down the pipe that we want to share with y'all, and we have some pretty A-list presenters as well. So thank y'all for being here. So we have to put this in here. As you can see, my colleague has much different disclosures than I do. And that's perfectly fine. That's okay. But yes, I have a few lines. Dr. Gia has a paragraph. But let us know. It's just how the world goes. It's okay. So anyway, the objectives of lung health. This is a great topic and a wonderful thing. We really appreciate the foundation for asking us and letting us partake in this. So the objectives that we wanted to really touch on that we saw in a lot of the submissions was that we really wanted to understand the state of the art of lung health outcomes in this new ETI era that people are calling. We certainly want to understand any up-to-date pulmonary exacerbation, microbiome outcomes that have a direct relation to pulmonary health and with CF across all ages, as well as some realistic findings, understanding those real-time challenges, those clinical scenarios, and shifts in how individuals are managing lung disease, infections, and conditions in people with CF. So we have a pretty interesting array of talks today. We're certainly going to talk about ETI and its development over time, tapping into the PROMISE study. We're going to look at some studies as well, looking at how do we use mucoactive therapies, nebulized medications in this time and period. Some of that is going to be with our CF STORM. We're also going to look at some of our microbiome studies, kind of some insights from the STOP2 study, as well as what it looks like for individuals who are coming off medication or not taking medication or having a realistic approach that we all see. I'm a pediatrician, that there's just some disconnect in understanding and actually how what you prescribe is actually what happens on the patient side. I'm a patient too, and I forget to take my medicine as well. It happens. And then some really interesting things that I think that a lot of people who, when they started CF work and research, is a really interesting component with some registry data looking at pregnancy in CF and how this affects lung health, which is something that is quite an impressive feat that we are now working with. So we got some all-stars here, but the one I want to call out is that we do have a sophomore in college that is presenting today. So if you could give a round of applause here. Okay. Yes, we have all these people with letters behind their names, but he's working on them and he's going to do great. Even more than that, we have some high school students and individuals from the Sparks program. If you could raise your hand and say hello. If you're in here, you're supposed to be in here. There they are, over there. And so if you could reach out to them as well. So we are really, I'm not calling any people old, but we're really stretching the breadth here with CF research today, okay? So without further ado, Dr. Solomon.
I want to say thank you to Spencer and Xijing, and thank you for that kind introduction, especially saying I'm a sophomore in college. I know I look really good for my age. So I'm weathering this storm quite well. I've already got an MD in that time frame. So I thank you guys very much for that kind introduction and the opportunity to speak. No, all seriousness. Also, I have to apologize. After I finish this talk, I have to go to another one to present in the same block. So it's not that I'm disinterested in this session, I just have to be somewhere else. So I apologize for that up front. So these are my disclosures. Spencer just takes a little time, and all this means is less sleep. So all that extra disclosures means. So I want to give a little background on the PROMISE study, which is a real-world treatment study of ETI in patients with cystic fibrosis and F508del. And so, as many are aware, there's been a lot of long-term data and more recent reports from the Vertex-sponsored clinical trials showing persistence of endpoints, including percent predicted FEV1 and BMI, out to quite a long time in these post-marketing surveillance studies that have been conducted. And in fact, they showed in the clinical trial setting, real-world improvements and consistency and stability of lung function more recently. And so that's all very reassuring. But the impact of the real world on lung function trends and on long-term outcomes is what the PROMISE study is hoping to achieve and understand that and what those trajectories look like. Last year, I presented initial data with a little bit of a cautionary tale about lung function. Today, I'll present more of a happy story of kind of the real world setting that mirrors these kind of endpoints. So this will be very much a happy tale, and no words of concern as much as we presented in the most recent. So the early PROMISE results, which Dave Nichols published from our initial studies, showed initial improvements as expected in the real-world setting of our key core endpoints, including lung function, sweat chloride, CFQR, respiratory domain, BMI, and/or BMI Z-score for the pediatric population. And it made some interesting observations, including maybe the first and only time we've had albeit a modest but significant correlation between reduction of sweat chloride and improvements of lung function in the form of predictive FEV1. But we didn't really find a lot of other observations in terms of certain groups that did particularly better or worse in the real world setting. And so we decided that this study bore more attention. And so we have been looking at other observations. And so, as I said, there's been a couple of cautionary tales. One of these was led by Scott Sagal and others from us from the core study, showing that there's a significant drop-off in patient-reported chronic therapy use with patients with PROMISE. And maybe more concerning has been this finding we've had more recently, for which a manuscript we have in preparation right now, showing that across the age spectrum of PROMISE patients, many in this population have a continued decline in lung function with a consistent slope pre and post ETI. So these are cautionary tales, but the PROMISE study was hopefully going to give us some reassurance overall in the population. So I want to now talk you guys through the PROMISE study for those that are less familiar, and introduce the methods of this study. So PROMISE is an observational prospective cohort study that's been conducted at U.S. centers and the CF-TDN in patients with at least one F508del allele, and basically was designed to establish a pre-drug baseline, initiate ETI by clinical prescription, and then describe the short-term and biological and clinical impacts, of which we've had a number of report outs, including the study led by Dave Nichols. And now we're in the kind of long-term and max benefit phase, so the sort of extension study, which has gone out to, for some patients, as long as almost 5 years for data. And so we're really going to show now how that data that we showed from Dave Nichols, showing pretty consistent improvements in key core outcomes, how that looks today in the real-world setting at this longer time frame. So in this study, initially we enrolled about almost 500 patients, and surprisingly, many of those patients agreed to continue throughout the visit 8, which got them almost at 5 years. And so about 280 completed through visit 8. And so we have quite a lot of data in the research, real world research setting for these patients by which we can make observations. So these patients represent a fairly standard demographics for an adolescent and an adult CF population. We did actually capture a fair number of patients of Hispanic or Latinx background. We did not capture a lot of patients of Black or African descent, which was a little bit to our chagrin, so that observations in those key demographic areas are a little bit limited. But otherwise, the populations was pretty balanced towards a usual CF population that we expect to see in the kind of real world setting. Interestingly, we did have a number of patients that were on ivacaftor before with a G551D mutation, but that number is pretty small. So you guys will see some observations a little bit with the pre-IVA treated group. Those numbers are pretty small, so I'm not going to make a lot of conclusions on those today because of that, because that number of population was pretty small. So let's look at the long-term clinical outcomes. And so first we'll start with FEV1, which is our key primary endpoint for the study. And as you can see, these are comparing populations that were on none or dual combination modulators or IVA alone prior to initiation of ETI in the study. See that at the 54-month time frame, these patients had a consistent improvement in lung function. The IVA group, again, has had a little bit of trend down back towards their pre-ETI switch baseline lung function. However, this is a small group, and they did remain at least numerically above where they had started from their IVA baseline. So not too much of a cautionary tale there. And the population that got switched over to highly effective modulators from either dual combination or no modulators had a pretty consistent improvement in lung function at that 54-week time frame. The sweat chlorides mirrored similarly. The IVA group, as expected, had a lower reduction in sweat chloride because they were already on a level of a highly effective modulator, but did have additional reduction of sweat chloride, as has been observed in other trials as well. And the no modulator or the dual combination patients had a pretty consistent reduction of about 40 millimoles per liter, which was consistent throughout the time frames in the study. Maybe the most cautionary tale that we've learned is that weight appears to be, weight and body habits appear to be an ongoing increase in many of these studies. This was observed in the post-marketing studies that Vertex released, and we're seeing also a pretty consistent increase in the adult populations of increasing BMI as these patients continue to take ETI. So that is the cautionary tale I know has been looked at in several studies already, and continues to be an observation that we're making, but it seems to be persistent increases in BMI. So I don't think CF patients are going to ever look like Spencer and I, we hope, but there's definitely an increasing weight in the CF population. And there appears to be in the real world and in the clinical trial setting, there appears to be an effect from ETI, which is, I guess you could be viewed as a good thing as long as it's kept in check. And so definitely will be a change for the nutrition world to think about as we go along with that. Similarly, in the BMI numbers, a similar increase in numbers across both the adults, which are done by BMI, and then the Z-score BMIs are pretty consistent in the adolescent population. Now, of note, we're not presenting the PROMISE pediatrics. There is a 6 to 12 cohort, which has been led by Felix, Ratjen, Margaret, and others, but we're not presenting that today. That will be coming at a later date as that study matures out to its final endpoints. So, because it's a bit behind, obviously, because of the approval times. And of course, we also looked at symptom scores. And so there's what I would say is a pretty consistent improvement in symptoms from baseline in the populations across the three modulator groups, with consistency of improvement in the respiratory domain and CFQR indicating improvement in health-related quality of life related to respiratory symptoms in this population. The other thing we're interested in is some of the biological implications of what we can find. And one of the most interesting, one of the leading questions we've had with the PROMISE core study has been, is there an effect of sweat chloride on that reduction? Does that really affect the endpoints? I think you all know, because this has been talked about at this meeting already, that the answer is there really isn't a lot of that. However, there is a consistent finding we're having with the lung function, which I'll show you guys in a moment. Otherwise, I'll say there's not, and that's not surprising, but I think the question that burns in everybody's mind is, why does sweat chloride reductions, if you continue to reduce that back to normal, why does that not have a bigger effect? Is it an individualized effect, or is it something else? And so we'll show that this data again, which is more evidence that there's a disconnect there, and why that is, I'll say I don't know. But so this is the data similar to what we showed from the initial 6-month data, looking at the correlation of change in sweat chloride reduction at the end time point, the 54-month time point, compared to their improvement in lung function. What you can see is that generally this bottom box here is sort of the improvement in both. The more you improve in both, the more you improve in sweat chloride or reduce the sweat chloride, the more your lung function goes down. But again, that similar relationship where there's a good bit of noise here resulting in sort of a modest correlation by which you could predict extensively for an individual patient is just lacking. So I think, again, we know that if you reduce sweat chloride in general, that's going to help, but we don't have a good predictive model here from this. And we've done more sophisticated modeling with this, and it's really just not showing a very predictive model. So I think we've got to have another biomarker to say, yes, your lung function is definitely going to go down better. It's just sweat chloride is not going to tell us, except for in a group-wise fashion. Similarly, and these correlations break down even a bit more if you look at BMI and weight. Similarly, those have a general trend towards improvement in weight or BMI with sweat chloride reductions, but no real significant correlations there in that data, shown here for the weight data for both the 18-year-olds and older and the adolescent population on the right, and then here with the BMI data, similarly, sort of the lower the sweat chloride, a little bit better BMI, but no significant correlation. So again, there's not a significant relationship biologically between those two, at least in this population. We have had some additional results, and some of that has been some subgroup analyses trying to answer questions that we've gotten before about, is there a particular effect in women versus men based on sex at birth? Is there a difference in different demographics and whatnot? And so I'll present a little bit of that, but in the interest of time, I'm not going to spend too much time on the tables. The whole data, because it's pretty extensive, is on the poster we put up, and I'm happy to share that with anybody if they want to email me at the end of the presentation. I'm happy to share that data because it's pretty extensive tables. So I'm going to show these are just some of the tables. They're pretty extensive we're looking at, but I'm going to go to the kind of conclusions on the subgroup analysis, say that there's really no apparent effect in our initial subgroup analysis achieved at the final time points for the key endpoints, looking at sex at birth, female versus male, and that's by patient report of their sex at birth. Age and enrollment does not seem to make a huge difference. Background modulator regimen, at least the the dual combination versus none at baseline. Now, there are differences in the IVA group. We anticipated that because those patients already had a semi-highly effective modulator on board to start with. So there are differences there, of course. But again, that's a small population, and we didn't really see significant other differences between those groups. And then also race and ethnicity. As I said, we did have a fairly significant Hispanic and Latinx population that was observed in the study, but we did not have a lot of patients that were of Black or Hispanic descent, Black or African descent. So therefore, we can't make a lot of conclusions. But what we can from the small amount of data, there does not appear to be significant differences in that group. So I think that tells us a lot of reassuring, right? That's great. From what we can tell from the small number of these populations, there doesn't appear to be significant differences by which we begin to make hypotheses of differences in outcomes and whatnot. So the drug works across a large population. We are beginning to examine differences in outcomes based on levels of key changes in inflammatory mediators that will be assisted by Scott Sagal, and then also with Pradeep Singh and Dave Nichols looking at changes in key infections. As we have learned, and it's been presented in this meeting already, there are reductions of key inflammatory mediators and key infections like Pseudomonas, but those do not go to zero. So those are probably driving some of the observations we're seeing as we drill down into the data more with the lung function trends and whatnot, but those are going to have some more exploration, so I'm not going to present that data today. But we have begun to make that observation, and there are already some key observations out of Marcus Mall studies and others from Germany looking at some correlations in level of neutrophil counts and whatnot, and some of the inflammatory mediators and lung function trends and whatnot. So we hope to add to that literature as we go along to better answer some of these core questions about lung function trends and outcomes long-term for patients in the real-world setting. So I'm going to conclude with that and say that the clinical improvements were observed over a 4 to 5 year time frame of ETI in the real-world population and PROMISE. These findings demonstrate long-term benefits and disease-modifying effects in adolescents and adults with at least one F508del mutation. They were similar but numerically lower than the 6-month data, but overall the trend looked pretty reassuring in a group-wise fashion. And then we have mechanistic investigations are underway to examine the relationship of some of these other observations made in some of the sub-studies to answer some questions about biology as we go along. And so I really want to thank you again for the opportunity to present today, and I'm happy to take any questions. Thank you all. I did want to acknowledge this study's been going on for quite some time. It's been a labor of love for many of us in the room, and so really want to acknowledge the people with CF that gave their time to this study and kept up with this for 5 years, coming for visits. Some of them a lot of visits, and then the site PIs and RCs. You guys have been great. Those are in the room, and the TDNCC team. I can't say enough how wonderful they've been getting us through this, and they will continue to shepherd us as we analyze more of this data as we go along. So thanks to all those folks that were involved.
Thanks, Dr. Solomon. You have a question?
Yes.
Hi, I'm Christian. I'm a junior with the Sparks program in high school. I was wondering, you mentioned sweat chloride, and I was wondering if sweat chloride was found in all humans or if it's a compound that's exclusive to individuals that live with CF, and if so, what are the causes of chlorine being found in sweat?
Let me see if I can give you the quickest primer I can on sweat chloride. Okay, it's a great question. Sweat chloride is actually a diagnostic and a therapeutic monitoring tool that we use in cystic fibrosis. So in the sweat ducts, the regulation of water and chloride and sodium, that's what makes up salt, are regulated partly by the CFTR channel, which is what we are studying. These drugs like ETI, which is a triple combination drug, they activate that CFTR if you have cystic fibrosis to some extent. And so what we're looking at there is we can stimulate the sweat duct to do something, and if the CFTR channel works, then chloride will come out of it. We can make measurements. If it doesn't work, there's a lack of resorption in the sweat duct through the CFTR channel to resorb and reclaim water and salt. And so the sweat chloride will be high if you have cystic fibrosis when you collect it on the skin and measure the concentration of it. And so as you can imagine, then if you have less CF because you've turned the channel on with one of these things, the sweat chloride will reduce. And so that's why we're very interested in that endpoint to try to understand how it reflects certain things that like lung function improvements, because that's reflecting how much the CFTR channel is active compared to, for instance, lung function, which is a key outcome for these patients.
Thank you.
Does that make sense to you? Okay, great.
Thanks. I just want to say that there's also, I guess it does work. I was just going to say, please let us know if you sent in questions and it doesn't work. We have a question from Maxwell Vetter. Moving forward, will there be any attempts to analyze biomarkers to better understand patients who have a poor clinical response to highly effective modulators and why they don't respond better?
Yes, we're right now we're trying to identify who are the kind of poor responders. But most patients are actually pretty decent responders in PROMIS. There aren't a lot of what you call poor responders, but we are very keen to look at those biomarkers to try to understand these patients, the pretty decent sized subset that's having persistent lung function trends. So that's a different, what we're presenting today, but is of keen interest to us, because I think that finding, which has also been observed with some of the ivacaftor data that's been observed more recently, and then other of these observational studies are sort of making similar observations. I think it's a provocative finding and not terrible, because we know that overall the population is doing a lot better still, but it is a concern for, as people live 20 and 30 years on these modulators, will there be problems with their lungs, right? So that's obviously an area we're trying to address, and we've not gotten to that yet, but that's one of the things we're obviously trying to address as best we can with PROMIS.
Yeah, and I'll just have a follow-up question to that
Sure.
too. I know you talked about some of the clinical characteristics that you're doing subgroup analysis on, and then you're going to explore the inflammatory biomarkers. I mean, one of the things that kind of comes up is or you'll probably look at FEV1, since it seems like maybe it's more protective for patients to start earlier, and those are people who may
Right.
respond better or not
Yep.
have that long-term decline.
So it's interesting that the slope of decline of lung function is actually, this is not just our data, but others have reported this too. That appears to be worse in the pediatric population than it is in the adults. So maybe it's because the adults have already had a period where they're in a lung function group, and they're obviously starting out at a lower lung function, as you can imagine, and more lung disease, baseline bronchiectasis and whatnot. So maybe they've already had the lung function declines they're going to have, and they're going to more slowly trend down now. But the pediatric population, actually, in our data, is actually exceeding the slope of decline is actually exceeding that. Now, that again is not the focus of this presentation, but since you brought it up, so I think that's concerning. But I think the BEGIN study and others were going to better answer the start early than the PROMIS will, but we'll get some hints as PROMIS PEDS reports out on that a bit too with the long term. So, Dave.
First, Marty, congratulations and thanks for leading this study
Yeah,
through
sure.
the end. Great job.
Yeah.
I know you didn't want to focus on the IVA treated, but that's the group that's had the longest exposure to what we call highly effective modulators.
Right.
I didn't know if you could provide any conjecture on what you think might be happening there.
I'll say I thought someone was going to ask that question. I tried to do some analysis to prepare for that question, and we only had about 30 patients that got IVA that went this far out. So looking at are there other things that are different with them? It doesn't appear to be. Now the sweat chlorides, of course, we don't know one thing we don't know is what benefit were they getting before? Was this a population that maybe their sweat, for instance, this is just one conjecture, their sweat was not as great. They had a suboptimal sweat reduction, and then they had, of course, as you can imagine, had only a smaller sweat reduction with the addition of triple, right? We don't know that. We also don't know how consistent they were with what kind of baseline lung function they got to with IVA to know, is there going to be a difference? The other thing that I question is there something about maybe that population, because they've had a lot longer with an effective modulator, have they been off of other protective medications for longer? All that's difficult to model with PROMIS because they kind of came in with that baseline. So that I think those are things we'd love to know. So we're probably going to have a different type of study to answer that question, but it's definitely provocative if we see more of it. So
Thanks a lot.
yeah, sure. Thank you for the good question.
Hey, any other questions? Okay. Thanks so much,
Yes.
Dr. Solomon.
Thank you all. Thank you.
Next, we're going to have Dr. Gwyneth Davis talk about results from CF Storm.
Thank you very much for the introduction to talk today, and welcome to those of you on the Sparks programme. It's great to have you in this session here. Here are my disclosures. So my name's Gwyneth Davis. I'm a clinical associate professor at the UCL Great Ormond Street Institute of Child Health in London and the UK, and I'm delighted to be presenting the headline results from the CF Storm trial on behalf of the entire CF Storm team. So here's a picture of myself and Kevin Southern, my partner in crime on the CF Storm team. We're co-chief investigators on this large randomized controlled trial, which is looking to assess change in respiratory function for people with CF established on ETI after rationalization of their nebulized mucoactive therapies. And we're specifically looking to answer the research question, can people with CF established on ETI stop nebulized mucoactive drugs without a significant fall in respiratory function at 12 months? And unfortunately, Kevin Southern is not able to be with us here today, but I'm delighted to be presenting this, as I said, on behalf of the whole team. And from the very start, this has been a trial that has been driven by the CF community in terms of really from the the underlying rationale for the trial in terms of addressing that key priority question of how can we simplify the treatment burden for people living with cystic fibrosis, driving that question, but designing a low burden trial rather than a burdensome trial to investigate that. We were designing this trial and getting things off the ground in the height of the pandemic, and therefore it was important to have a trial that was able to be delivered both in person but also remotely, and quite a lot of the components of the design reflect that. We also had a clear steer from the CF community that the focus of this withdrawal study should be on withdrawing mucoactive therapies as a group rather than looking at just Dornase alpha or hypertonic saline in isolation or in that respect. And because we wanted to be able to deliver this as a low burden trial and be able to deliver it remotely, we're lucky in the UK to have the infrastructure from the UK Cystic Fibrosis Registry to support this. And we already had some early understanding from the CF trial, which is a randomized controlled trial in infants with cystic fibrosis, which predated CF Storm, which is used in this infrastructure. And we were able to significantly further develop that with CF Storm, incorporating functionalities such as electronic consent, the ability to capture patient-reported outcomes, and to have a trial-specific questions as a study module that could both import directly data that were entered into the core registry, but also have some specific questions, therefore facilitating this trial delivery in a way that was of low burden to participants. So here's the eligibility for CF Storm, the key inclusion criteria that people had to be established on ETI for at least 3 months, and they had to be on a daily prescription of either Dornase alpha and or hypertonic saline, again for at least 3 months. Our minimum lung function enrolment was percent predicted FEV1 of 40. And when we started this trial, we had a minimum age of 12 years, but reflecting the licensing age of ETI down to 6 years during the course of the trial, and also some challenges with recruitment, we lowered that down to 6 years of age in October 2023. We wanted people to be clinically stable at enrolment and therefore had a stipulation that there was no acute antibiotics within the prior 2 weeks. And of course, because this was a randomized registry trial, they had to be enrolled on the UKCF registry. Because this was a pragmatic trial, we tried to minimize the exclusion criteria, but they are as they are listed there. And then in terms of the intervention and the comparison, so this is a randomized controlled trial with a one-to-one randomization of participants to either the stop group, for which the intervention was withdrawal of their existing daily mucoactive treatments for whatever people were on at the time of enrollment. So this might have just been Dornase alpha, it might have been Dornase alpha and hypertonic saline, or it might have been hypertonic saline alone. And the comparison group is the continue group. And these people continued their daily mucoactive nebulizers therapies. The primary outcome for our study was change in percent predicted FEV1 between baseline and week 52, and these are the headline results that I'm going to be presenting today. The secondary outcomes are listed here, equally important, actually, particularly looking at pulmonary exacerbations, hospital admissions, need for extra antibiotics, but also the ability, particularly because of the duration of the study, to look at those longitudinal patterns and change in FEV1 and nutritional outcomes, as well as quality of life measures and an economic analysis looking at treatment costs. So CF Storm is designed as a parallel arm randomized controlled trial. It's a non-inferiority design, and we have a non-inferiority margin of 3%. This is the same margin that was used in the Simplify trial, which is a trial that you'll all be very familiar with, that reported 2 or 3 years ago now, which was a discontinuation trial looking at discontinuation of either Dornase alpha or hypertonic saline over a 6-week period. So we have the same non-inferiority margin as Simplify, but actually we defined that independently of the Simplify team through discussions with collaborators and also engagement with the CF community about that. So we required 257 participants in each arm for 80% power, and allowing for 10% missing data, we had a recruitment target of 572. I just wanted to go over a couple of relevant protocol definitions that are particularly pertinent to the primary outcome results. So the timing of our encounters on the CF registry, we wanted to have a baseline percent predicted FEV1 within 14 days of randomization and an end of study data entry 51 to 55 weeks after randomization. CF Storm is very much delivered as a study that is within routine care, and we didn't have participants coming for additional study visits, so this was fitting in with usual clinic visits. And I would particularly want to highlight that end of study interval because that's relevant to our data as we move forward. Then in terms of spirometry, as I said before, we had the ability to deliver this study remotely, but also so people had the opportunity to use home spirometry if that was something available to them, or have their spirometry measured in clinic. But we did stipulate that whichever modality was used, that it should be the same at baseline and end of study. In terms of the database and statistical analysis, so our last participant, last follow-up was in August 2025. So you can see why this is very much a hot off the press result. We locked our database as planned on the 30th of September 2025, and the CF registry team in the UK and the clinical trials unit team at the Liverpool Clinical Trials Centre did an absolutely phenomenal job to get everything in line, ready to go with the analysis once we had locked the database, because all of the data cleaning had been already prepared. The analysis relevant to the primary outcome being presented today, this is an intention to treat analysis that I'll be presenting with an ANCOVA model for the primary outcome, also looking at the split between age group of 6 to 11 versus 12 years and over, and according to FEV1 bands of 40 to 70, 70, 90, and over 90% predicted FEV1. We also did a sensitivity analysis looking at extended visit outcomes for, extended visit windows for these clinical outcomes on the registry. As I've slightly alluded to already, particularly with the end of study, that interval created some challenges with the pragmatic design of this study. So we performed a sensitivity analysis for that. So here's a recruitment slide. You can see our very overly optimistic target patient, our little line saying the target patients here. The orange horizontal line is our 80% power line there at 572. Our actual recruitment is in a dark red line, which is somewhat difficult to see because it very much sort of follows the royal blue line. But you can see there that we did achieve over the 80%, the 572 number in August 2024, and we recruited 591 participants to this study. And in terms of who those people are, so our mean age in our population was 21.7 years. The age groups here are classified according to the UDRA CT database defined age groups, but of course we have 6 to 11-year-olds rather than 2 to 11-year-olds in our group. But just to highlight that there were 106 6 to 11-year-olds in our study population with the splits, as you can see there. And then in terms of the study population and what treatments people were on at enrolment, the Dornase alpha, 69% were on Dornase alpha alone, only 4.1% were on hypertonic alone, but actually that is quite reflective of the UK demographics the UK prevalence of hypertonic saline use alone in our registry population at a population level, and 26.9% were on both treatments. In terms of the baseline ppFEV1, we can see there the alignment between the groups, but overall the 89.4% was our mean FEV1 for the participant population. So the primary outcome, looking at the intention to treat data. So we, as I said, randomized 591 participants. We had 88% of people who had a baseline FEV1 on the registry within these 14 days of randomization. But unfortunately, we only had 77% of people who had their end of study within this 1 month window at that end of follow-up time. So we had 390 people, which is 66% of our randomized participants who had an FEV within these protocol specified windows at baseline and at 52 weeks, and these represent the numbers that go into our primary analysis. So that's what I'm going to present now. So here we have our summary of our FEV1 at baseline week 52 and the week 52 minus baseline results for the stop and the continue group. And you can see here that the week 52 minus baseline, which is the bottom row in this chart, is the mean difference in the stop group was 0.15, and in the continue group was minus 0.79, with an overall of minus 0.32. And when we look at that in terms of the ANCOVA model, we can see that the mean difference between the stop and the continue group in these 390 participants was a positive number. So this is favouring stop, a mean difference of 0.97. And this is well within our 3% non-inferiority margin, because you can see there that the lower end of the 95% confidence interval is minus 0.5. And this is just a bit of a recap as to how you might understand non-inferiority results. So you can see here that anything to the right of 0 would favour stop, anything to the left favours continue, and you can see our margin there of the -3. So with what I've just shown you, you can understand that the direction here favours stop, and that the lower end of our 95 confidence interval was well within that non-inferiority margin. This perhaps is a little bit small on the screen, so apologies for that, but this basically shows us the change from baseline to week 52, split by treatment group, according to whether people were randomized to stop or continue. And you can see that there's a real overlap between those groups. So irrespective of whether you were randomized to stop or continue, these were the either positive or negative directional changes in FEV1 according to the group. And you can see this data presented in both ways here, but up to plus or minus 20 in both groups, but no striking differences between stop or continue. And then when we looked at the primary outcome data according to baseline FEV1, you can see here that we looked at minus 40 to 70, 70 to 90, and 90 and above. And you can see that for all of these groups, there was a direction that favoured stopping, again, with all of the lower 95% confidence intervals within that -3 margin. So we confirmed non-inferiority for stopping nebulized mucoactive treatments in all of these severity groups. We also looked at this, as I said, in relation to baseline age, 6 to 11 versus 12 and above. Again, we can see that the direction here favours stopping. Particularly, you can probably struck by the magnitude of that mean difference there in the 6 to 11-year-olds and the confidence intervals there. But again, we can see that all of the lower bounds of the 95% confidence intervals are above -3. So as I've already said, we wanted to design a pragmatic study. If we were to design this again, we absolutely would not have just a 4-week period to capture data at the end of the study for this type of registry trial. But because it's a registry study, we have that opportunity to utilise some more of the registry data that we didn't necessarily have access to in the trial database. So we were able to submit a data request, which was reviewed and approved by the UK CF Registry Research Committee to look at data from CF Storm participants prior to that randomisation date, taking those data on the CF registry nearest to that randomisation date up to a maximum of 90 days. Within the CF Storm data and the trial database, we were also able to retrieve data for an extended visit window at the end. So whereas our primary analysis is based on that 51 to 55-week post-randomisation window, we had a sensitivity analysis that could capture anybody's FEV1 on the registry captured within 40 weeks post-randomisation to that maximum 55. And of course, we use the primary analysis data where possible, but otherwise the closest in that to week 52 was used. And by doing this, we were able to considerably increase the number of people that were able to contribute to our analysis. So here you can see that with those extended windows, we have 95.8% of people that now have a baseline. We have in study end 93%. And in our outcome set with these extended windows, we have 528 participants, 89.3%. And importantly, this gets us over the numbers that we required for those original power calculations. And here's this similar slide to what we showed for the primary outcome data. This is the outcome data summary for those extended windows, now with 528 participants rather than 390. And what you'll be struck by is an extremely consistent message here in terms of what the magnitude of change is within these groups and the overall change here. And when we look at that within the model, we can again see that the mean difference between the stop and the continue group favours stopping. Again, the lower bound of the 95% confidence interval is well within that non-inferiority margin of -3. And just because I know this is a bit of a memory test, so just to put them both up there at the same time, here's the primary outcome summary in terms of those protocol-defined visit windows and the primary outcome when we had the extended visit windows, and obviously the different numbers of participants contributing to those data. But actually, you'll be struck by how consistent those mean differences are and the lower and the 95% confidence intervals. And I wanted to highlight here the Simplify results to remind those of you of this. We've always seen CF Storm as really contributing to the body of evidence is accumulating now for the withdrawal of mucoactive therapies in an ETI era. Our results are extremely consistent with the intention to treat analysis from the Simplify team, both for their hypertonic saline results and their Dornase alpha results. So that was really exciting to see because, as I said, CF Storm is over a 12-month period and Simplify was over a 6-week period. So to be able to confirm that over a longer period of time. So in summary, involvement from the CF community has been really central to the design and the overall ethos of CF Storm. This has included adopting a pragmatic and inclusive design using the UK CF registry. We've definitely had some challenges along the way, and these have included recruitment and the balances of delivering a pragmatic registry study with the regulatory constraints of a clinical trial of an investigational medicinal product, which is as this trial was viewed by our regulators in the UK. And for people with CF established on ETI, we've shown that stopping mucoactive therapies is unlikely to adversely affect FEV1 over 12 months for our study population here, being at least 6 years of age and with a minimum FEV1 of 40. As I've just shown you, the primary outcome results align with Simplify and will contribute to the evidence base to support shared decision-making about long-term therapies for people with CF established on ETI. But analysis of secondary outcomes, including health economics assessment, are ongoing and will add context to these important results. And it's extremely important that we see that to understand a full picture of the interpretation of these results. I've put on the bottom of this slide the study website address where we have some key timeline updates of when we'll, in terms of presenting results and when further dissemination will be available. And then just to finish, this is a huge team effort. As I said, Kevin Southern is my co-chief investigator. I'm very sorry that he's not here to be with us this morning. But I just want to acknowledge the whole team in the Liverpool Clinical Trials Centre, particularly Abby Williams and Lindsay Finetti, the statistics team led by Ashley Jones, and all of the people at the CF Registry and the CF Trust who have helped deliver this study for us. Thank you also for the participants that have contributed their data to the CF Registry and to this particular trial, and to all of those in the UK that have facilitated and made this happen. And we feel that the results are going to be really impactful for our CF community. And thank you for listening. I'm happy. Happy to take any questions.
Alan Smith from Belfast. Gwyneth, thank you for a really clear presentation of a very, very important study. And what shines through in this presentation is this is co-production with the patient community from conception to delivery, and fantastic turnaround by the Liverpool team. I think database lock to results was 6 days, so that's extraordinary. Do you have any plans to use, because this is a registry study, do you have any plans to use the registry for further follow-up? Because this tells us what happens up to 12 months, but what might happen after that? And given that this is nested within the registry, could that be a tool to allow us to do that?
Yeah, I certainly think that one of the advantages in hosting these sorts of trials in the registry is that opportunity for that longer term follow-up. And I think because the registry captures start dates and stop dates of chronic treatment and we'll be able to have detailed understanding of that, I think we need to explore ways in which we can continue to follow up the outcomes of these people, because as we're hearing more and more in these conferences, that kind of longer term perspective is very important. 12 months is long, but it's not long in the kind of now the lifespan of somebody living with cystic fibrosis. Thank you. Greg.
Thanks again. Greg Sawicki from Boston Children's. Alan took my first question about long-term follow-up because I think it's going to be very important. My other question is there any way, was there any way to ascertain whether the people that were randomized to continuing therapy, whether they actually continued therapy or did they actually stop, or do we not know?
So, I mean, I've just presented the intention to treat data here. I think we have a lot to look at in terms of the adherence to trial allocation, etc. We did look at that in a number of different ways. We asked trial participants whether if they'd been randomized to stop or continue, whether they'd restarted any of their treatments. We asked their clinical teams. We have the detailed information on the registry about their treatments. We also, for those people in the study who had a opportunity for electronic data capture with their nebulized devices as part of standard care, to be able to look at their nebulized use of therapies. The difficulty with that is over the time period of CF Storm, there's been quite a lot of changes in the availability of those devices or the programs which were supporting some of the devices that had the ability to capture, for example, chipped nebulizers. So we actually really won't have much in the way of electronic data capture for nebulizers. I think because our groups seem so different, I think it feels like we've got different groups with stop and continue. I think that it's absolutely important, particularly for a non-inferiority to design, to understand where that crossover is going. But I think ultimately this is a pragmatic study. This is what's happening in the real world, and this is what we find.
Okay, thanks.
Thanks, Greg.
I do have a follow-up question to that too. I understand this is a real world intention to treat analysis, but do you have any baseline characteristics data in terms of adherence for the patients who randomized prior to randomization? So we only had around 10% of our participant population who did have a device capable of electronic data capture. From memory, their mean adherence to the nebulated therapies was over 70% at enrollment, but I don't have any more detailed information on that. But because of the complexities of we've really going to have very little data at the end, I don't think that's going to be, I mean, it's useful to understand that
enrollment, but unfortunately, I don't think we'll have the kind of 12-month follow-up data for that.
Thanks.
Thank you.
Any other questions? Great. Thank you so
Okay.
much, Dr. Davis.
Sorry, all the chat just came through. I apologize.
We do have a couple of minutes.
We have a couple minutes. Gwyneth, if you want to come back up here, sorry. Sorry, Gwen. Ashley Keller asked, one of the limitations
Oh, that was done.
Simplify was that the mean FEV1 of the population study was roughly 97%. Can you remind us what the mean FEV1 was for CF Storm?
Thank you. Yeah, I think that's another real positive finding from CF Storm, and that our mean FEV1 was 89% at enrolment, and that is really consistent with what our mean FEV1 is at a population level on the CF registry, and very much fits with this being a trial that is relevant to a wide population with a wider FEV1 spectrum than Simplify over a longer period of time. So thank you for that question. I think that's a really important difference, and I think that just highlights why these studies are all complementary and are really sort of important.
Okay, got another.
Still not allowed to go.
No, sorry. Carissa Cam said, will there be a sub-analysis of patients that were on Dornase versus hypertonic saline only, given the Simplify results showing these continuing on Dornase had a negative impact on mucociliary clearance?
Yes, I think that our... so firstly to say that we have hardly any participants who are only on hypertonic saline, but I think the results in relation to Dornase alpha are of interest, particularly because of the direction of change that we see in the group randomized to continue, particularly those with very well preserved lung function, and particularly those in the younger age group, in that their direction of change suggests, is sort of favouring the whole direction of change is favouring stopping rather than continue. I think that it adds, the mucociliary clearance findings in Simplify were really interesting for hypothesis generating. I think our results are very consistent with those mucociliary clearance findings from Simplify. I think they're also consistent with some analysis that's done prior to modulators in the CF registry population, looking at impact of Dornase alpha in young children with CF with very well preserved lung function. And I think this is a story that we need to understand more about as we go forward to ensure that we're doing the right thing.
Yeah.
Can I escape?
Yes, great
I
question.
don't know.
Okay, all right. Next we have Alex Pitchler, who's going to talk about impacts of gaps in ETI therapy in adults with CF.
Hi, good morning, everyone. My name is Alex, and I am an undergraduate student at the University of Washington studying bioengineering. I'd like to begin by thanking Doctors Gia and Poor for inviting me to speak today. I am very grateful for the opportunity to be able to share the research that we've been working on with you all. So without further ado, let's take a look at the impact of gaps in ETI treatment in adults with cystic fibrosis. I have nothing to disclose. So I'd like to begin with a clinical case. Here we have a 20-year-old male with cystic fibrosis, genotype F508del homozygous. This individual started taking ETI in January of 2020, and in August of 2023 lost health insurance and stopped taking ETI and was lost to follow-up. The patient then represented with acute respiratory failure in the setting of rhinovirus and enterovirus infections and was hospitalized in December, 4 months later. Let me direct your attention to the right-hand side where we have the graph of the FEV1% predicted of this patient around this gap. So as you can see, this patient started off with a phenomenal baseline lung function at 122% predicted. That's amazing. And when they were hospitalized, that dropped to about 24% predicted. That's about a 100% drop in FEV1% predicted. That is substantial. Associated with this decline in lung function was also a drop in weight. At baseline, this patient weighed about 73.3 kilograms, and then this dropped to 56.7 during their hospitalization. That's a 14 kilogram drop, which is also substantial. That's a big deal. Now, if we look at what happened after they started ETI again, they did regain some lung function, but they did not make it up to their original baseline above 100%. So this example just goes to show how important studying gaps in ETI can be. It also provides a baseline or a framework for how we look at the rest of this study. So let's talk about some things that we already know. We already know that elexacaftor, tezacaftor, ivacaftor, otherwise known as ETI, is shown to improve lung function and reduce exacerbation rates in people with cystic fibrosis. We also know that interruptions in care in people with cystic fibrosis is not uncommon, and these are associated with negative outcomes. Previous analysis of the registry data have linked interruptions in care to declines in lung function, and indicators for these increased risk in gaps include adolescents transitioning from pediatric to adult clinics, as well as those with limited access to health insurance, as we saw earlier, and also male gender. And furthermore, observational studies following patients on ivacaftor, which is one of the 3 components of the ETI, found that withdrawal can trigger symptoms resembling pulmonary embolisms and a rapid decline in lung function. And when I mean rapid, I mean within days. Very, very fast. So this study had 2 specific aims. One, to determine how interruptions in ETI treatment affect lung function, exacerbation frequency, and hospitalization ER visit frequency in people with cystic fibrosis. And 2, to determine the timeline between these interruptions and these clinical events, such as hospitalizations and ER visits. And also, we also aimed to look at if recovery happened and the timeline to recovery. So to answer these questions, we looked at 69 people with cystic fibrosis from a specialty pharmacy who were provided ETI prescriptions. And this is out of a total of 291 prescribed ETI at the University of Washington Clinic. For each of these patients, we assessed ETI adherence using a metric known as medication possession ratio. For those of you who are not familiar with it, MPR represents the ratio of medication dispensed versus how much medication was prescribed. This was also calculated using pharmacy records for delivery of ETI to patients' homes. And the timeline of this calculation was from January 1st of 2023 to December 31st of 2024. Once we had an MPR for all individuals, we then categorized them into 3 groups. One being the major interruptions group with an MPR of less than or equal to 75%. 2, the moderate interruptions group having an MPR between 75 and 85%. And 3, those with minor to no interruptions having an MPR of less than 85%. For all individuals, lung function in both FEV1 and FVC in liters and percent predicted were followed, as well as ER visits, hospitalizations, clinic visits, antibiotic use, and weight. Now, one thing that MPR does not account for is reduced dose of ETI. So manually, we went into each patient's chart and we looked for those with reduced dose. And if we found individuals that were on reduced dose for ETI, we readjusted their medication possession ratio to 100%. And this was to account for artificially low MPRs. Now let me introduce you to our cohort. Out of the original 69 patients, 5 had to be excluded in analysis because their baselines were very old and way outside our range, and also before ETI was around. So out of these 64 patients, 12 of them had an adjusted MPR of less than 75%. 10 had an MPR, or adjusted MPR, between 75 and 85%. And 42 had an adjusted MPR of above 85%. Now, it's important to note here that 22 of 64 patients had an adjusted MPR of less than 85%, which, less than 85%, that's not good either. So that's a substantial portion of our population. The mean age of our participants was 37, mean BMI was 25 about. And one thing that was interesting in this cohort was that the percentage of female participants started going up as you go up adjusted MPR groups. So that followed what we saw earlier with males being at increased risk for having gaps in care. Those with cystic fibrosis related diabetes, there were a higher percentage of those individuals in the adjusted MPR between 75 and 85%. So that was something that also stuck out and was interesting. As for baseline FEV 1% predicted, we found that those with adjusted MPR below 75% had the lowest mean FEV 1% at baseline. And the other two groups had roughly similar, around 80% predicted. So overall, when we looked at lung function and body mass index over the course of the study, we saw quite a bit of variation, as you can see here. If I direct your attention to the left, we'll see the change in FEV1 over the study. In the center, we have change in FEC percent predicted over the study. And to the right, we see change in BMI. Now, none of these numbers are statistically significant, and there's a lot of variation here. So we can't make any conclusions. But what we do see is that the group with the lowest AMPR had a lot more variation than the other groups. And so we took a very deep dive in looking into what was going on there. So to do this, we looked into each of the 12 patients' charts, and we found that 5 had switched centers or changed pharmacies during the course of the study period. So that was an explanation for why their adjusted NPR was so low, because they had less drug because they had switched halfway through the study. And looking into this group of 12, we also found 7 with confirmed gaps in their charts, or gaps in ETI confirmed by their charts. And so we took a look at those 7 patients and we explored what was happening over time. So let me introduce you to these 7 patients. As you can see, all of them had drops during their gaps. So the gray shaded regions here indicate when gaps occurred, and the red asterisks indicate when their baseline was taken. So one thing to note is that a few of these individuals had very, very sharp declines in lung function that were associated with pulmonary exacerbations, like the 2 that we see at the bottom. We also see that in some of these patients, there were, elements of recovery. In the top right, we see that this patient recovered to above their baseline, but a few of the patients did not recover. Now, if we take an average of these 7 patients, we'll note that the median gap range was 100, or the median time in gaps was 140 days, and this ranged from 13 to 663 days. So there was a lot of variation in how long these gaps were. You'll note that in the previous slide, there was a very, very long gap on the top left, and there was also very, very short ones. That 13-day gap is indicated on the bottom row right there by that little gray sliver. But that does not necessarily mean that there was any, lower drop in lung function due to a lower gap. This individual had a total crash in lung function. In terms of baseline lung function, the average percent predicted was 73.6%. The standard deviation was 27%, and it ranged from 32 to 122%. The average change in FEV1% predicted during these gaps was about 20%, and this was a decrease for the average of all participants. As for hospitalizations and ER visits, the median time to hospitalization was 108 days, and this ranged from 13 to 146 days. Events that we noted were four out of 4 pulmonary exacerbations in these 7 patients, and 1 admission for diverticulitis. Now, overall, this study had 2 main limitations. One being that NPR and adjusted NPR do not necessarily reflect a patient's usage of ETI, but merely how much ETI they had on hand. We noted that in several of the charts there were mentions of patients who had a high NPR, but were not taking NPR or ETI due to bouts of depression or anxiety. There are a lot of reasons why people would not be taking it, but this is not reflected in this metric. 2, being that we were only able to get data on 69 of the 291 adults prescribed ETI at our clinic, because we were working with 1 specialty pharmacy. So to summarize, we saw that low adjusted NPR for ETI was not uncommon in the UW clinic. There were quite a few individuals with an AMPR of less than 85%, and 7 out of 64 participants with an AMPR of less than 75% is not a small amount. We also saw that lung function and weight were overall maintained across AMPR groups, but then again, we had a very large confidence interval, so it's hard to make conclusions. We also saw that in those with the lowest adjusted NPR, their durations of their gaps were often substantial. And when we looked closely, we noted that lung function declined and hospitalizations and severe exacerbations were seen and observed. Now, this brings me to my final point, being that understanding the usage of ETI from people with cystic fibrosis and the relation to clinical outcomes is and will continue to be an important area of clinical research. So with that being said, I'd like to thank you for your attention. I'd also like to thank Dr. Christopher Goss and the amazing team at the University of Washington for being such amazing mentors to me. I learned a lot in this research project, and I also got to learn a lot about the amazing CF community. So thank you so much. And also thank you to the study participants who we followed. So thank you. If there are any questions,
Thanks.
yeah.
I'll just start it off with one question. How did you guys determine the cutoff points for the NPRs? Was that based on a mechanistic reason for ETI efficacy, or is that where the patients fell? Because it seemed like it wasn't necessarily by thirds, the three groups that were looked at.
Oh, so you mean like the cutoffs for the
The 85 versus 75.
Yeah, those were all defined a priori, so defined beforehand. There's, as far as I know, in clinic, there's not a defined way to, categorize NPR. So those were just defined to look specifically to find those individuals with those gaps, but also, to create some sort of metric for that.
Thank you. That was great. Really interesting. I'm curious about people that you saw that may have had an NPR greater than 1. Did you see much of that? Greater than 100%.
That's a great question, because NPR, as you probably know, does not get capped at 100%, like some other metrics to measure that. So we did see a few with an NPR of over 100%, and that's of course due to overlaps in prescriptions during the study period.
Yeah, that's what we've seen as well. The specialty pharmacies do a pretty good job of pinging our patients and letting them when it's time to reorder. And so we looked at this at our center in Portland a couple of years ago when we found out that many of our patients had more than 100% and sometimes up to 4 to 6 months of medication. Mm-hmm. So our pharmacist did a great job of implementing a protocol so that we look at this about quarterly so we can identify people that have excess medications and we can ask them to hold off on reordering so that they don't end up with excess medications that's lost. So.
Yeah, that's something that we also noted. Thank you.
Thanks. That was an excellent presentation, and congratulations for also being really upfront with the limitations on this kind of analysis. I think that's really important to upfront. But I have a few questions on those that had a lower NPR. Mm-hmm. Maybe two small numbers, but if you did chart review, were you able to get any data on payer type or what types of insurance they had? And did you were you able to look at NPRs on any other medications to see if it's an overall picture of having challenges with filling prescriptions?
Yeah, that's a brilliant question. So in terms of looking at the types of insurance, we did not record those. We were mainly just looking if patients changed insurance as an explanation for a low NPR, but that would be a very, very interesting thing to look at. And then as for other medications, we mainly looked at ETI. We did follow also some oral antibiotics that are commonly used in cystic fibrosis. But other than that, mostly ETI.
And then, I know you identified gaps, people that sort of stopped and started, but were there any of those situations where it was clear from looking at the charts that it was actually a decision to stop therapy as opposed to, not filling prescriptions, like a discontinuation as opposed to a gap?
Yeah, also another great question. So in the charts, when I was looking at them, there were a few decisions, mostly to reduce dosage, and then those individuals were rescaled. But that was mostly what I saw in looking at the charts myself. There were decisions mostly to reduce dosage. Most of these gaps, I can tell you, if we go back, but that's a far ways away. A lot of them were one individual was moving and stopped, picking up their ETI, or it wasn't delivered. They were moving houses and got very busy. People were, quite a few things with health insurance, but I don't recall any decisions to make to stop ETI.
Hi, I'm Kristen Klein, and I'm the CF pharmacist at Michigan Medicine, and I also work with our specialty pharmacy. So I thought I'd provide a little bit of clarification about NPR and targets. So For example, at our institution, we consider patients with CF to be a high-risk category of patients, and so our target NPR is 90%. And as we are doing our quality improvement and quality assurance every quarter, we actually have to investigate if any of our target groups are not meeting their NPR threshold. And so it's possible that your accreditation body or your institution itself set 85% as their target for cystic fibrosis, and that may be why a priority 85% was set as the is that upper limit target.
Thanks so much. I just have a follow-up question to that. So I think a lot of us want to understand what is the threshold of missing doses of ETI, or what is the what's that threshold that that patients would still experience clinical benefit or not clinical decline. So is there any, sorry, I hope that makes sense. So is there any plans of looking long-term at patients either at your site or at other sites too, and doing some sort of dose missed analysis or a days missed analysis to understand what is that threshold that patients don't have long-term lung function decline?
Yeah, so that threshold is pretty difficult to find because a lot of people react differently to ETI. I personally saw a lot of variation. There were some individuals who only missed a little bit and had a huge decline in lung function, and then there was also individuals who missed quite a bit and then didn't seem to react that much to it. So then looking long term, I think that the team at the University of Washington, we're going to look more into these thresholds, and especially look at the group with 100% AMPR and see what's going on over there. How are they looking? And then that's definitely an area that is very important to look into, because that would be very good to know for people with cystic fibrosis.
Thanks.
Oh yeah, and then
I would only say there are a number of us have used NPR in different studies. And actually, the weaknesses of it are actually quite substantial when you start to look at the granular data. And that's, I think, what's a lesson in this study is, and if you're just looking at administrative data sets and you're only looking at the difference between 185 could be someone who's skipping a reduced dose and someone who's not using any of their dose. It's actually sort of fascinating. So what is a cut point, but it's sort of what it means, and can you use these in a valuable way to help sort of follow your patients in clinic? And we hope to get one of the challenges is our disconnected sort of healthcare system, where we have 6 specialty pharmacies and even that's not all the pharmacies that do tezacaftor. So it's we don't have a system within the United States to easily track that throughout because we use so many different pharmacies. And if you talk to Kristen Riker, who has done a number of projects with NPR, the challenge of getting these numbers for your patients is actually really remarkable when we don't have a unified healthcare system, when you can't just know what was delivered to your patients.
Yeah. Also, adding on to that, I had an interesting conversation with a woman from Italy yesterday as I was presenting my poster about insurance. Because, here in the United States, we don't have universal healthcare insurance. And over there, overseas, they have a completely, she seemed a little bit, it was just a very interesting conversation to have about our system here and about how this can influence what happens. So, yeah. Are there any more questions?
Yeah, you're not done yet. Sorry.
Oh, okay. Wonderful.
Okay, there's one in the chat. It somehow missed on my iPad, but I get when you send chat messages, they email all of them to me as well. So can you explain the drop in FEV1 even before ETI interruption in the patient is depicted in the graphs for some of the patients? With a kind of a leading question is next is, do you have any data points in between interruption and baseline FEV1?
That's a really great question. And I can tell you that, the lines were a little bit deceiving. Those were not continuous lung function measurements, but just a line connecting, the dots. And so that, I have gotten quite a few questions about that. Like, oh, it's declining even beforehand. There were, a few small variations. Would it help to go back to the slide? Yeah.
I think you're good.
Yeah, but I can say that those lines may be a little bit deceiving there. And then the second question was about, oh yeah, if we had any measurements from between those points. So
Between baseline and interruption.
yeah, also another great question. So unfortunately, the way that it is that those who missed their ETI or had gaps in ETI also happened not to come into clinic very often. And so there was, surprisingly, that was a challenge in the study, is that those who we looked at who were already missing their ETI doses, we don't have a lot of data there. And so we did our best. We found as many lung function measurements as we could, and that's what we came up with.
Last one.
Hi, Pınar Ergenekon from Marmara University, Istanbul, Turkey. I would like to share our results. It was published a study by us last week about interruption highly effective modulator therapies. In Turkey, highly effective modulator therapies were not reimbursed until June 2025. So the patients received these therapies by court decisions, and for this reason, we saw some interruptions during the treatment periods. We published a study about 250 patients with interruption periods, and we saw these declines like your studies during these periods, and we saw that they could not catch the FEV1% predicted values like after the treatment. So I would like to highlight that we can see these results in low and middle income countries like us with receiving these treatments interruptions and unintentionally. Thank you.
Awesome. Thank you for that.
Thank you. Next, we've got Dr. Raksha Jain, and she's going to tell us about a CF Foundation registry analysis of pulmonary exacerbations and lung function in pregnant versus non-pregnant patients with CF.
Okay, thank you. First, I'd like to congratulate Alex. That was a phenomenal presentation. I wish my college-age son was here to see what a really great undergrad student can do. Unfortunately, I think he's probably still asleep. And thank you for the organizers for having me. I'm actually presenting this project on behalf of our fellow Netta Bianchi, who had to leave early from the meeting. So thank you for allowing me to present this. This was a collaborative effort from a number of the investigators you can see here. This is my presentation disclaimer, as well as my disclosures. So as many of you know, in the era of ETI, we have really seen a baby boom in the number of pregnancies in females with CF. It really nearly doubled, and this has stayed consistent since the availability of ETI here in the United States. With that, a number of questions have come up of what are the implications of being pregnant? Can I, what does that mean for my health? What does it mean for my baby's health? And I think as we just heard beautifully, many of us are really, for the most part, keeping a lot of our patients on ETI because some of these interruptions can have a real impact on their health. I just wanted to highlight some of the studies that have been published over the last several years, mostly prior to ETI, but these are some of the ones that have either used large data sets or multi-center studies. This was a really nice one, again, fairly old, but using a California database where they tried to compare the outcomes of pregnant females with CF versus pregnant people without CF, in theory, healthy controls. Here, there was only 77 mothers with CF and 2 million people without CF, but some of the things they found were that those mothers with CF were more likely to have gestational diabetes during their pregnancy and have higher rates of C-section. In addition, they found that their neonates were more likely to be born preterm, meaning before 37 weeks. In another large data set using the nationwide inpatient sample that was done using data between 2000 and 2010, they actually had over 1,000 mothers with CF and 12 million without CF. Here, they actually found an increased risk of death in those mothers without CF. They found that they had more pneumonia, more preterm labor, and again, more gestational diabetes. So what do we know moving the time frame just a little bit further? And this was a study published in JCF in 2021 that actually included multiple sites across multiple countries. It was actually 10 sites across Israel, Europe, the United States, and Chile. And here they had 171 pregnancies and 128 people with CF. They actually looked at lung function, so the y-axis in all three of these graphs is FEV1, and they took a look at it, dividing people with mild and what they called moderate or severe disease, and that mild versus moderate and severe was really broken down by FEV1 and BMI. They took a look at those who were colonized with Pseudomonas or without Pseudomonas, those who are pancreatic sufficient versus insufficient. And you can just see what they saw was, at least in the mild versus moderate to severe breakdown, there was no real difference in FEV1. They did also look at some infant outcomes and did find, however, that that moderate to severe group did have more babies that were born premature. When looking at the people colonized with either Pseudomonas or those who are pancreatic insufficient, they actually did see an initial rapid decline in their lung function in that first 1 or 2 years post-delivery, but that's stabilized later. So in other studies, actually looking at this question of survival in pregnant versus non-pregnant women, this is actually a relatively recent study published this year by Paul Mohabir and colleagues at Stanford, and they took a look at our CF Foundation registry using data from 1999 to 2019. So it did span some of the modulator era, but not quite the post-ETI period. And as has been published by others in the past, they actually found no difference in survival probability doing Kaplan-Meier, and they took a match group of pregnant women and non-pregnant women, as you can see here. So that's good news relative to that database I just mentioned a second ago. They also looked at Cox regression analysis, and here actually found that the pregnant group had better outcomes, a lower hazard ratio, 0.78, and they found no significant association between pregnancy and lung function overall. Again, not really giving us data about ETI yet, but important information to share with our patients that overall the long-term impact, particularly on survival, is good. I will mention that the reason the Cox regression analysis and that survival probability is different is because we do still tend to see that the women who become pregnant often have a higher lung function overall. There's another study that myself and a group of investigators around the country, actually 11 sites, all here in the United States, did, looking at data from our own centers between 2010 and 2021. So just starting to capture the ETI era. In these 307 pregnancies, actually 114 of these moms were on CFTR modulator of some sort, and of those, 77 were actually either on ETI or ivacaftor. And if you can see, we looked at data basically 1 year prior to their pregnancy, during their pregnancy, and 1 year post. So those are the 3 time points you see on these graphics, looking at FEV1 on the top left, the prevalence of Pseudomonas, and pulmonary exacerbations. And if you look, the red bars are the group on no modulators, the group in gray are on highly effective modulators, and in blue on other modulators, which were typically the dual combination modulators. So you can see here that we saw in terms of FEV1, the only group that had a notable difference was those on no modulators in red, where they did have a decline in their FEV1 of about 2.5%. And this has been consistent with some of the other literature pre-ETI that's out there. When you look at prevalence of Pseudomonas, we saw a dramatic decline only in the group that was on highly effective modulators, again, consistent with some of the data we've seen out there. But again, the caveat that some of these people just didn't have sputum samples that were able to be collected at all. And then you look at the bottom on pulmonary exacerbations here, and you see that overall, just the highly effective modulator group had a difference, and that was that they had a rate ratio or a decrease in their pulmonary exacerbations, with that rate ratio being 0.54. There was a number of limitations to this study, and again, it only looked at relatively short-term outcomes, and this was in a period just after ETI had been approved, which also impacted a little bit of our analysis. So what we know, to the point of what our question was, that there's no survival difference that's been reported in females with CF versus those that become pregnant versus those that don't. There are some studies that do show a tendency towards a decline in FEV1, others that show stability. We see a higher rate of gestational diabetes and higher rates of C-section. but really the impact of long-term pulmonary exacerbations is not yet known. And I know this is a question I get from my patients when they're thinking about becoming pregnant. So we wanted to take a look at this and use the CF Foundation Patient Registry, which is an invaluable source of information, and focused on data between 2012 and 2022 to evaluate females between the ages of 18 to 50 to answer these questions, including the pulmonary exacerbation events, which we defined as use of IV antibiotics, and changes in FEV1 over time using longitudinal regression models and the GEE equation. So our study group ended up including, as I mentioned, 18 to 15-year-olds, those who had at least 2 years of data in the registry for pulmonary exacerbations and for percent predicted FEV1, and the age range or the date range I mentioned, 2012 to 2022. So what we were able to include in our analysis is 5,000 females, or 5,609 females with CF, and of those, 3,402 did not experience a pregnancy ever. 2,207 did. And I think this is also remarkable to see that if you look in this time frame, 40% of females in CF in this age range of 18 to 50 are experiencing a pregnancy. I would have really never thought the numbers are that high, but I think it's really phenomenal and wonderful to see. So this is a table of our demographics. It's a little bit busy, but I just want to note a few things that overall, things such as age in the two groups were not really different, with a mean that was about 29 in each of the groups. The racial distribution, not significantly different. The Hispanic ethnicity, not significantly different. Then you look at use of modulators when it came specifically to ETI and ivacaftor. There was more use in our pregnant group. You look at diabetes, there was more diabetes present in the non-pregnant group. You look at other things such as the prevalence of Pseudomonas aeruginosa and Staph aureus. That was actually more prevalent in our pregnant group, and we adjusted for these or accounted for all of these in our model given those differences. Also, just looking at FEV1, this was a little bit of a challenge because the way we did this analysis, it was just looking at whether they had ever experienced a pregnancy versus never experienced a pregnancy. So how to find a time to match their FEV1 was difficult. So we at least looked at it as time of first FEV1 available, and that there was a difference where overall, when you look at some of the higher FEV1s, that was more prevalent in the pregnant group, whereas the lower FEV1s were more prevalent in the non-pregnant group. We also took a look at the FEV1 just prior to pregnancy to understand where they were right before they were becoming pregnant. Many of them had lung functions over 60%, the vast majority. But if you can see here, there was actually about nearly 5% that were under 40% in their FEV1 immediately before becoming pregnant. We also took a look at number of pregnancies because that's something we don't often have the opportunity to do. This was another thing that was incredibly surprising to me, where about 41% of our population had one pregnancy, 32 two pregnancies, and then everybody else, which is nearly 30%, had 3 or more pregnancies, including people who had 7 or 8 pregnancies, which was completely shocking to me. Kudos to them. But we did take a look at that a little bit, which I'll share with you as well. So starting out with our first outcome, which was annualized rate of pulmonary exacerbations in this pregnant group and non-pregnant group, we first just did an unadjusted model, a rate ratio of what were the pulmonary exacerbations. So it ended up being 0.87, meaning actually in the pregnant group, there was a 13% fewer exacerbations in that pregnant group. Again, that is unadjusted. And keep in mind that the FEV1 overall in the pregnant group was a little bit higher than the FEV1 in the non-pregnant group. Then when we controlled for or adjusted for all those variables that I told you were a little bit different in our demographics, we actually found no difference with a rate ratio of 1.03 and a non-significant p-value. So really what that says is very good news that when you take into account some of these differences in the population, that the rate of pulmonary exacerbations in someone who becomes pregnant is no different than someone who does not become pregnant. We looked at a few other additional things. We wanted to take a really close look at our post-ETI period that we had, which was 2020 to 2022. So we did a sensitivity analysis just honing in on that time period. And actually you can see here that in the unadjusted model, that difference we saw before went away. So no difference in the unadjusted or the adjusted model in our now post-ETI period. The other thing we wanted to look at was the impact of these 1, 2, or 3 or more pregnancies. And here you can actually, and very surprisingly to me, we found again, no difference whether they had 1 child versus 8 children, et cetera. So actually really good information, because again, I think questions that come for patients are, once I've had 1, that was all really hard. Can I handle another? Keep in mind, this is general information. Every individual is still going to be different, but I think it gives us nice information to tell them that, at least from the pulmonary exacerbation standpoint, women who have multiple pregnancies are still doing well. And then we took a look at FEV1 over time. This is really just looking at FEV1 in the pregnant group, which is the solid line, versus the non-pregnant group, which is the dotted line, and took a look at it over time, where the left-hand side is in an unadjusted model, and that right-hand side is adjusted for all those number of variables I mentioned to you earlier. And as you can see, again, the pregnant group sits higher than the non-pregnant group throughout, but there was no difference overall. And I also think it's really, interesting and fun to look at FEV1 over time in the population this way, because you can see that, of course, across both populations, there was a trend towards a decline that comes back up post-ETI. But again, I think it will be very interesting to follow this out a little bit longer term and find out what happens to the FEV1 really once we're 5, 10 years out, as we're seeing in the PROMISE study. And what does that mean, especially as more people tend to have babies and build their families. But good news is, when you look at the trajectory overall, the trajectory was no different between the 2 groups. We also tried to take a look at breaking down the same FEV1 trajectory by their FEV1 at start, and we broke these groups into those who had an FEV1 greater than 80, 61 to 80, 41 to 60, and less than 40%, just to look at their trajectories. And there was a statistical difference, but I will tell you, when it comes to actually the percent changes, they were very nominal, so I wouldn't call it clinically significant. The one area where we actually saw a little bit of a difference was in those pregnant people who had an FEV1 less than 40%. You can see that is the group on the right-hand graphic in the very bottom, where you can see this trend towards them declining. Fortunately, it does look like they started to stabilize after ETI, but really it's hard to pick these things out in an analysis the way we did it. So the reason, statistically they look different. I would not say clinically we really truly know the answer yet. So really, just to conclude, good news, we saw no differences in annual rate of pulmonary exacerbations between those who are pregnant versus non-pregnant when we accounted for the number of factors that we could, from age to FEV1 to diabetes and pancreatic insufficiency and even microbiology. There was no difference based on number of pregnancies. The FEV1 trajectory remained non-statistically different between the 2 groups, but the FEV1 in the pregnant group remains a little bit higher than the non-pregnant group. And finally, there was this little bit of a trend down in the FEV1 in that low lung function group that looked like it was stabilizing post-modulators. So there's definitely some limitations to this study that I want to acknowledge. First of all, it was retrospective. Second, in these large data sets, we really can't directly correlate any of these pulmonary outcomes to pregnancy. We can just really say that there is an association between that. We did try to adjust for a number of variables that are available in the registry, but we really didn't have granular data on such things such as diabetes control, which was highly prevalent in both populations, on care oversight by an OB-GYN team, which can make a big difference, or in adherence to medication. So I think these are things that, as people look within their own centers, all of these things may matter. We were also very limited in infant outcome data, which I think people are always curious about, and that is really because from the registry standpoint, the large portion of the data only collects whether there was a live birth or not, and so it really didn't allow for an in-depth analysis of any kind on that aspect. So in terms of future directions, as you know, a lot of these questions that we aren't able to answer from these large data sets, we're hoping to answer from a study that's being supported by the CF Foundation and TDN by Jennifer Taylor-Kauser and myself, called the Mayflower Study. That is where many of you in this room have probably participated as sites, and we've finished enrolling now 312 participants in that study. We're going to have very detailed information on the mothers, their health pre and during their pregnancy, as well as the births, and very importantly, are following their infants at birth and for 2 years post-delivery to get some information there. And finally, we also hope to take another look at pregnancy outcomes in people with CF versus a population that doesn't have CF to understand, is this even still a high-risk population? Because I think that will guide us on our care as well. So with that, I just want to thank, first of all, the fellow that led this project, Netta Bianchi, as well as the study team I worked with, all the people of Sharing who do a lot of work in the reproductive health space, my team at UT Southwestern, and a huge thanks to the people who are willing to participate in the Robust CF Foundation Registry, and Liz Cromwell and her team, who are always so great at allowing us to use this great source of data. And I'm happy to answer any questions.
Raksha, there's a quick one in the chat that you just kind of mentioned. Stephanie was curious, did you include all pregnancies or only that resulted in live births was the question.
That's a great question. I should have mentioned that. So it was all pregnancies independent of the result of the pregnancy. Now, a few things to understand about the registry is the way it's put in from sites is that it just says pregnant in that year. So sometimes that pregnancy can span 1 year and sometimes it can span 2 years. So we had to spend some time that if they were back-to-back years, we counted that as one pregnancy. And whether or not people entered pregnancies that didn't result in a child, we don't know. That is a limitation to the study. So we just know whether they were pregnant or not. But that's a terrific question. Yes.
Raksha, thanks very much. I think that might partially answer the question I'm about to ask. Notwithstanding the changes to pulmonary mechanics that come with advanced pregnancy, there's also an increase in estriol and estrogen in general throughout pregnancy as well. Your group and others have led the way in CF in terms of sex hormones and their effect on inflammation and exacerbation frequency. Is there any way of looking at these data by trimester to see if within particularly the Pseudomonas cohort, there is an increase in exacerbation frequency beyond that expected for advanced pregnancy, potentially owing to the effects of estrogen?
Yeah, that is a great question. Thank you. I love that question. And so basically, using the registry, obviously we can't because there's no data sets, but the Mayflower study, we actually did collect blood samples at every trimester. And that is something that we're hoping to do is look at actual hormone values and correlations between pulmonary exacerbations. The one limitation of the Mayflower study that will limit some of that is that we did not collect sputum samples. And so we're only going to be able to look at blood inflammatory markers, but we will be able to look at pulmonary exacerbations. But it's a great question and very interesting. Thank you.
Thanks, Rich.
Fascinating talk. Chris Calkins, I'm an adult pulmonary fellow at Stanford. I was struck by the bacterial colonization data being particular, I think it was for staph and Pseudomonas being slightly higher in the pregnancy group. That colonization information, is that at any time point during the study, or is that actually pre-pregnancy colonization?
That is a great question. So we basically defined it as 2 or more positive cultures across the entire study period. So whether or not that was way early on in our registry analysis or later, we don't know. And whether ETI after ETI, we would see less, I would assume, but we didn't look at it that way. That's a great point that maybe we need to think about a more detailed look at that.
Yeah, also it's sort of interesting to think about the immunologic changes during pregnancy and if somehow that's implicated. But I guess perhaps in Mayflowers, you'll be able to see that with the data you have.
Yeah, maybe. That's going to be a really difficult question to answer, I think, because again, depending on how you want to define their immune response, et cetera, we're not going to have any, cells that we can capture at the moment. It's all going to be bank samples and it's all going to be bank blood. So we're going to be limited a little bit, but it would be really interesting to know based on what we know about general population and their immune response during pregnancy. Thanks for that question and comment. Can I go? Yeah. Thank you.
Thank you. Lastly, we have Dr. Lindsay Caverly, who will talk to us about the lung microbiome and clinical outcomes during antibiotic treatment of CF exacerbations from the STOP2 study.
Okay, thank you for the introduction, and I appreciate the opportunity to be here today to talk about this study that we did on the lung microbiome in the STOP2 trial. So I'll start with a little bit of a background that pulmonary exacerbations continue to be important events in people with CF. Chris Goss gave a great talk on Thursday at the exacerbation session that gave some STOP 360 data that showed that exacerbations needing treatment with IV antibiotics still happen in people with CF. They still are clinically significant, and they're still quite costly and burdensome to people with CF. And exacerbations, we know, are heterogeneous clinical events. They're heterogeneous in their presenting symptoms, which can include different combinations of cough, sputum production, lung function decline, fatigue, chest x-ray changes, or weight loss. Heterogeneous in their contributing factors, which can include, again, various combinations of bacterial infection, viral infection, mucus obstruction, inflammation, comorbidities, or even life events that may impact medication use, and so forth. And also in terms of treatment outcomes, including the degree and timing of lung function and symptom recovery. And these are not exhaustive lists for any of these factors. But despite the known heterogeneity in all of these aspects of exacerbations, the treatment is relatively uniform, and I'll qualify that a little bit and touch back on that later. But sort of at a high level, exacerbations are diagnosed and they're treated with a high-level standard approach of antibiotics, airway clearance, and comorbidity management. But there has been interest in trying to identify different types of exacerbations that potentially could be identified and then used to refine our treatment approach and hopefully result in improved outcomes for exacerbations in people with CF. And I'll highlight one study in this area from the investigators shown here that looked at pulmonary exacerbation phenotypes in people with CF using systemic markers of inflammation and viral infection for phenotype identification. And our interest has been in looking at the airway microbiome and thinking about how variation in the microbiome can relate to the heterogeneity of exacerbations, and ultimately, how can we use that knowledge to help potentially guide exacerbation treatment and improve outcomes. And so to do this here, we did an ancillary study to the STOP2 study, and I'll give you just a brief review of the setup of this. This was a randomized clinical trial of antimicrobial duration for CF pulmonary exacerbation treatment, and it enrolled adults with CF at V1 who were starting IV antibiotic treatment for exacerbations. At V2, shown here about a week into treatment, they were assessed for their clinical response to treatment. If they had an early robust response based on clinical symptoms, they were assigned to the ERR group, randomized to either 10 or 14 days of antibiotics. However, if they didn't have that early robust response, they were assigned into the NERR group and randomized to either 14 or 21 days of antibiotics. So for our ancillary study, we took sputum samples from these 3 study visits, so V1, V2, and V3. And asked the questions, can the airway microbiome at antibiotic initiation predict exacerbation treatment response? And then similarly, do changes in microbiome with exacerbation treatment relate to clinical response? And we hypothesized, consistent with sort of conventional wisdom for how antibiotics are working in exacerbation treatment, that more change in the microbiome across the course of treatment would be associated with a better treatment response. So we ended up having a collection of just over 1,300 sputum samples from 704 adult participants in the STOP2 study. Only 187 of those participants were able to produce sputum samples at all 3 visits. And with these sputum samples, we characterized the microbiome using 16S rRNA gene sequencing, and then we also did ddPCR to quantify total bacterial load. And recognizing that our cohort was a subset of the larger STOP2 cohort, we first looked at the demographics of who we had represented in our sample set to make sure that it was comparable to the larger STOP2 cohort. We broke this down by the early robust responder or the non-early robust responder group, as the STOP2 study did, understanding that these were pretty clinically distinct groups in the STOP2 trial. And we were relatively reassured that our cohort was pretty similar. I'll highlight just a couple of pieces of information here, and that is that our ERR group was younger than the NERR group, had a better baseline lung function, and also presented to the STOP2 study with a bigger drop in lung function compared to baseline. So again, consistent with the larger cohort. Oh, and this was mostly completed pre-modulator, so very few of the participants were on highly effective modulator therapy. So the first question we asked was, how much population level change is there in airway microbiome with antibiotic treatment? And we took just a high level look at this. This is a NMDS plot based on Bray-Curtis dissimilarity. So dots that are closer together are more similar, dots that are farther apart are more different from each other. This is representing only the subjects who had sputum samples available from all 3 visits. And we colored these dots, and the circles are by the visit. So you can see sort of big picture, there's not much of a signal by visit. And when we looked at this in terms of the percent of variability that these contributed to the data, the subject had the vast majority of the variability. So 75% of the microbiome data variability was accounted for by the subject. The visit only accounted for just over 1% of the variability, which maybe is surprising since these people were all getting antibiotic treatment. Maybe you'd expect more community movement. But on the other hand, this is pretty consistent with what we've seen in many microbiome studies, where the within subject variability really accounts for the biggest part of the data variability. So to work with this, we first performed some data reduction to try to take away some of the subject variability and to put things into some biologically and clinically relevant bins that could help us guide our analyses. And we did this in a couple of different approaches. I'm going to focus on one approach here, and this and the other data analyses that I'm presenting were mostly led by Lisa Carmody at the University of Michigan. So a couple different complementary approaches to grouping the relevant microbiome features, but I'm going to focus on how we group things by the dominant genus. And we define this by the most abundant genus in the microbiome data was present in more than 2 times the relative abundance of the second most abundant genus. And when we applied this to the data set, this is how things panned out. So we had 4 groups that fell out of this. One group that was dominated by Pseudomonas, the top bar there. One group that was dominated by Staph aureus, which is the second group. Another group that was a little more of a mixed bag that was dominated by other taxa, and this included smaller numbers of people dominated by Chromobacter, Burkholderia, a small number that had anaerobes that met the definition of dominance, and then a final group that had more diverse communities at the bottom that did not meet the dominant taxa definition. And with this grouping, we first asked the question, can airway microbiome at antibiotic initiation predict exacerbation treatment response? And so we first approached this by taking a model based on clinical variables, and these are clinical variables that have been shown in other studies to be predictive of clinical improvement of exacerbation, such as age, baseline lung function, how much your lung function dropped at exacerbation onset, how many exacerbations you've had in prior years. And we looked to see if adding the microbiome data could improve upon the clinical data-based model. And we found that we did see improvement in this. Presented here are the p-values for likelihood ratio tests comparing the linear models predicting clinical improvement. And I'm giving the examples of adding in visit 1 Shannon diversity, which is a diversity metric that takes into account how many different taxa are present and what the distribution of the relative abundance are, and then our dominant genus categorization that I mentioned on the prior slide. And you can see that the visit 1 dominant genus resulted in the greatest improvement in the linear models predicting clinical improvement for both lung function change from visit 1 to visit 2, and symptom improvement, which was measured by the CRIS survey from both visit 1 to visit 2 and visit 1 to visit 3. So we also looked to address the question of airway microbiome at antibiotic initiation predicting treatment response. We looked at the microbiome clinical correlations based on the dominant taxa. And so one interesting point of this is that these correlations differed by the dominant taxa. So here we looked at lung function between visit 1 and visit 2, broken down by how people were categorized by dominant taxa at visit 1. And you can see that the biggest amount of clinical improvement from visit 1 to visit 2 was found in people who were staph dominant at visit 1. They had the greatest FEV1 improvement across the first 2 visits. We also looked to see within the groups who were dominated by staph or Pseudomonas, and we focused on these groups as these groups are those that are most prevalent amongst people with CF. We looked to see does the relative abundance of these taxa relate to lung function improvement over the study course. So here we have lung function improvement by visit 1 Shannon diversity, and we have it separated out by Pseudomonas dominant and staph dominant groups. And I'll start with the orange line. This is the Pseudomonas dominant group. And you can see that greater Shannon diversity is associated with greater lung function improvement between visit 1 and visit 2. And this tells us that more diverse Pseudomonas communities, which is a proxy for having less Pseudomonas in your sputum sample, has greater improvement. But interestingly, when you look at the staph-dominated group with the blue line here, you see the opposite relationship. So less diverse staph communities, or people who have more staph in their sputum samples, had better lung function improvement, which is a little bit counterintuitive because I think we typically think of having less of your CF pathogen as being a better prognostic marker. So that was looking at visit 1 features as predictive of clinical response. We also looked at this in terms of, do changes in the airway microbiome relate to treatment response? And this is just a visual depiction of sort of the heterogeneity within this group. These are stacked bar charts of the relative abundance of the taxa in the sputum samples. And these are just 2 snippets, one of the Pseudomonas-dominated group in the light blue, and the second one in the dark blue of the staph-dominated groups. Each column is a person, and so if you go down across the columns, you're looking across visit 1, 2, and 3. And you can see just sort of eyeballing it, that there's a lot of heterogeneity, that there's some people who have Pseudomonas that stays solid all the way down. There's some people that have quite a bit of change if you go down across the columns. And so we're interested in how that heterogeneity in change across the visits may relate to clinical outcomes. So first we looked at this in terms of the ERR and NERR groups. As I mentioned before, these were really clinically distinct groups, and the STOP2 study gave us a great framework for having that as a clinical outcome to investigate in terms of the microbiome changes. And we looked to see if community movement was associated with whether people ended up in the ERR and NERR group. And it did. So here's the visit 1 to visit 2 Bray-Curtis change. And so more microbiome change across the first 2 visits were seen in the ERR group compared to the NERR group. We also looked to see how this change in microbiome across the visits was related to clinical improvement. So here we have lung function improvement related to Bray-Curtis dissimilarity between the 2. And you can see there's a correlation here between having greater change overall in your microbiome and your lung function improvement. And this was at sort of the population level, but then when we broke that down by the dominant taxa groups, we see a little bit of a different picture. And it turns out that the overall association between community change and lung function improvement is really driven by the Pseudomonas dominated group. So this is highlighted here. This is again the same y-axis of lung function improvement and x-axis of Bray-Curtis dissimilarity representing microbiome change. And you can see that really the strongest relationship is within the Pseudomonas dominated group. So if you're Pseudomonas dominated, your microbiome changes more across the course of treatment, you tend to do better in terms of lung function improvement. But that relationship doesn't hold up nearly as strongly if you're staph dominated or if you're dominated by other taxa or not meeting that dominated categorization. So a couple challenges and next steps that we took away from this. One, our V1 samples were all collected at the time of IV antibiotic initiation. We didn't have samples available from before the onset of exacerbation or in the early symptom period. We know that oral antibiotics are often given before IV antibiotics start, and so those could potentially have impacted the microbiome data that we used from V1. Antibiotics were given for all of these exacerbations, which was part of the study design. To follow up on this, I'm working with Christina Thornton at the University of Calgary on an ancillary study to the Stop Peds RCT, and this is also with the Stop Peds leadership group to look to see if quantification of the CF pathogen or viral infection at the onset of exacerbation in pediatric exacerbations can be used to predict whether or not kids can have successful antibiotic-sparing management of their exacerbations. So more to come on that. And then I wanted to get back to my statement earlier about exacerbation treatment being relatively uniform. We know that there's a lot of variation in terms of the specifics of the antibiotic regimens that people receive. And so we've had discussions with folks from the STOP2 team about how we can take some of those specifics of the antibiotic regimens, layer those onto the data of the microbiome changes in relation to clinical outcomes, and see if we can get more information by looking at more granular antibiotic data. We also, as I mentioned, had a small number of participants who were on ETI. The STOP2 team did a great look at the people who were on either lumacaftor, ivacaftor, or tezacaftor, ivacaftor within the STOP2 study, and those groups did seem comparable to the overall STOP2 cohort. But how this applies to people who are on ETI, I think, is still to be seen. And so, in summary, I think these data demonstrate that airway microbiome are a component of exacerbation heterogeneity. We found some associations with clinical outcomes in terms of response to IV antibiotic treatment. These associations did differ depending on the dominant taxa, and I think are relevant for identifying exacerbation types and thinking about using the dominant taxa, using information on the relative abundance of the CF pathogens, and thinking about considerations for future studies of exacerbation. And clearly this isn't ready for plugging into clinical care, but I think is hypothesis generating for how these types of data can help with binning exacerbation types, maybe stratifying for clinical studies and thinking about how we can better direct exacerbation treatment. I'd like to thank the team at the University of Michigan. Again, Lisa Carmody led these analyses, John LaPuma, Linda Calican, and then Genli and Dongri Dai, and then Christina Calgary at the University of Thornton, and then also Christina Thornton at the University of Calgary, and then the members of the STOP2 team, and then the STOP2 study sites and participating centers and participating people with CF and the CFF funding. Thanks. Happy to take questions.
Okay, Lindsay, we have in the chat from Maxwell Vetter. In the Pseudomonas dominant group, do you have a breakdown of how many patients were chronically colonized versus a new acquisition and how that may have affected antibiotic response and improvement in lung function?
Short answer is no.
Okay.
We don't have data on the chronic Pseudomonas status. I think people with chronic infection tend to have higher relative abundances of Pseudomonas, and so my guess would be that it's more heavily skewed towards chronic Pseudomonas infection, but I don't know the answer to that for sure offhand.
So I have a question. So I was struck by your stacked bar graph of the relative heterogeneity at visit 1, 2, 3. And I would have thought that visit 1 would have been more diverse than 3 as you get more exposure to your antibiotic course. Can you remind us if the sputum at visit 1 was predominantly collected after antibiotics were already started and that's why, or am I misinterpreting that slide?
Visit 1 was collected at the start of IV antibiotic treatment, but some people had received oral antibiotics beforehand, and there was a little bit of variation in terms. I think Chris can help out with this. I'm going to phone a friend on this one. The timing of antibiotics varied, so some people had received a dose of IV antibiotics, some people were pre-IV antibiotics, but oral antibiotics was a factor as well.
Yeah, the oral antibiotic rate was about 50% had failed oral antibiotics, and it just tells you a little bit about our clinical practice and exacerbation in the United States. And we do have that data. So I think it's actually worth looking at this on the Wisha class, because I think Sonia can get you the data of who was on oral antibiotics when they rolled into the study. And I think we even have data about when the sputum was collected before or after, because some study visits occurred. So we'll actually be able to tell that because people are enrolled and then their antibiotic start date was later. And so sputum was collected at baseline at the study visit, but they may have not been able to get antibiotics for another 48 hours. It really depends where antibiotics were given. The patients enrolled in the hospital have almost all uniformly received antibiotics, IV antibiotics before. But before that collection of sputum. So, but we have that data, so it's worth probably drilling down. But I had a very separate question. It's like I always get, with the publication of CF Matters trial, how do we think of this data? And I think they're going to be publishing. I'm not sure, somewhere, maybe not here, but I know that they also have microbiome data that's coming out of that study. I think where they used antibiotics directed toward the microbiome, and it really had no effect at all. So how do we sort of square these sort of different, and maybe they got the phenotype wrong, and of the microbiome? But love your thoughts.
Yeah. I think the study design of that was quite different from this, and they used a prior sputum sample to characterize the microbiome and then direct treatment, which often happens several months down the road. And so I think my takeaways from our STOP2 study is not so much microbiome-directed therapy, but whether we should be thinking about more about the CF pathogen in terms of do you meet a dominant type definition? Can the relative abundance of the CF pathogen be helpful in terms of anticipating how you're going to respond to treatment? So rather than sort of a whole microbiome, not thinking about covering all of the taxa that are in the sample, but more thinking about the characteristics of the CF pathogens that are there, and could that be used for sort of stratifying treatment or better understanding changes with treatment, how that relates to outcomes. So if you have Pseudomonas and your antibiotics are changing things more and you're doing better, is that different from if you have Pseudomonas and your antibiotics are not changing the communities as much?
Yeah, I think that makes sense because clinically, a lot of times I'm looking at their cultures or patients' cultures over the last 6 months or 2 years, and I'm covering everything that I see. And do I really need to add that staph coverage if it's 95% Pseudomonas, or do I need to add the Pseudomonas coverage that I saw at one time point if the majority of what's causing disease is staph? Yeah.
It was a great talk. Really enjoyed that. My question, I love the idea of looking at microbiologic predictors of correlates of clinical response. My question is going to be about relative impact or change with antibiotics intended to target traditional conventional pathogens, the ones you identified, and then the relative impact on the other stuff. And I wondered if you quantified that, like how presumably these are people who are either on maintenance antibiotics on occasion or they've gotten repeated courses of antibiotics before. So I'm curious how much for an acute exacerbation you saw in sputum with IV antibiotics. Things changed that were intended to change and things changed that were not intended to change.
Yeah.
So those off-target effects.
Off-target, yeah. Not specifically. The analyses so far have focused on the impact on the CF pathogens and also on the sort of community changes as a whole. But in terms of drilling down into specific other taxa that change and how that relates to outcomes, that we haven't focused on that as much, but that's a great idea.
Well, thanks,
Thank y'all.
everybody. Thanks, Dr. Calverley.